A very good afternoon to all of you. Today I'll be talking to you all about drug dosing during dialytic therapy. By far, drug dosing during dialytic therapy is one of the broadest topics in human medicine. The aim of drug dosing during dialysis is to maintain pharmacokinetics so as to achieve a desired pharmacodynamic response without any adverse side effects. That is, you need to maintain a steady state concentration of the drug, or you need to maintain a similar peak or trough of the drug. In critically ill patients, determining the appropriate drug dosing is challenging because of the PK/PD changes that occur in them. Traditionally, the dosing of the antimicrobials in patients with AKI is extrapolated from a single dose observations in non-critically ill patients with stable CKD receiving scheduled intermittent hemodialysis. Um, so, hence, there is a need to individualize the antimicrobial regimen. This is a challenging task for the clinician. Further, this is challenged by lack of standardization in terms of the type of RRT the patients receive, in terms of the ultrafiltrate rate, the blood flow rate, the type of filters we use, the duration of RRT, and so on. Now, the FDA also does not require the PK studies of drugs to be conducted in patients with AKI or those receiving CRRT for the drug to be approved. PK studies in CRRT have been conducted in less than 20% of the currently marketed drugs. The vast majority of drugs are dosed using a one size fits all approach. Now, if we look at all the drugs available, we can roughly divide the drugs into three broad categories. That is, the drugs which have a wide therapeutic index, like the antibiotics, drugs which can be used by titration to the effect, like your antihypertensives, and drugs which can be used by therapeutic drug monitoring. By far, among all the three categories, that is the last category, that is drugs where the therapeutic drug monitoring is available, or of least priority to us when we talk about the PK/PD of drug in patients with AKI. Sepsis with multi-organ dysfunction is the most common cause of AKI in critically ill patients. And sepsis has a different inflammatory media, and we are still continuing to understand the pathophysiological process of sepsis. AKI alters the pharmacokinetics of the drugs by affecting the absorption, the distribution, metabolism, and excretion. Absorption of especially oral drugs is affected with AKI because it changes the transit time, it alters the gut motility, it changes the gastric pH, and it also alters the first pass metabolism. In AKI, even the creatinine clearance is decreased, which is an obvious consequence of the altered tubular function. And not only the renal clearance, there is growing evidence to suggest that the non-renal clearance of the drug is also affected. Non-renal clearance basically happens to multiple organs like the liver, lung, intestine, and so on. Among all this, hepatic metabolism and the transport to the transporters is of importance to us. As I said, hepatic metabolism is the largest component in the non-renal clearance, which we can also call as the hidden drug clearance because it usually goes unrecognized. AKI results in a decrease in the non-renal clearance of the drug, but it is not always to the same extent as in the ESRD patients. In AKI, they have studied the effect of AKI on cytochrome P450 in animal models. Changes in the cytochrome activity in a particular organ of an individual cannot be extrapolated to other organs of the same individual. Observations made at the cytochrome level may not be translated to clinically meaningful changes in the PK. If you observe here, In the animal models with AKI, they have observed the effect of AKI on the cytochrome P450 subenzymes. Their certain enzyme activity is increased, certain there is no change, and certain enzymes the activity is decreased. If you look at the 3A1 subunit, the activity is increased, suggesting that drugs which undergo metabolism through this particular isoenzyme are excreted more rapidly compared to uh, patients without AKI. But this is not true in clinical practice. The metabolism by the drug transporters is also decreased during AKI. Basically, the transport through the drug excretion through the transport happens through the organic anion transporters, and the P glycoprotein also plays an important role in the transport of lipophilic compounds. The expression of both the organic anion transporter 1 and 3 is decreased, thereby decreasing the renal clearance of many drugs like your methotrexate and NSAIDs. In AKI, again, for drugs which have an active metabolite like your morphine, the drug effects are prolonged, and the drug effects even last for longer periods after the drug is stopped. As I said, the acute kidney injury affects even the non-renal clearance. It has been clearly shown that once such patients are initiated on RRT, the non-renal clearance during AKI itself will improve. This is because the potential toxins are removed with RRT or plasma exchange, and they reverse the AKI associated non-renal clearance changes. Two examples which are given are done on telithromycin, and the other is the erythromycin breath test. In patients who have AKI, when RRT was initiated, it was found that within 2 hours after the end of RRT, the telithromycin concentration and exposure was similar to that in healthy individuals. And in patients after 2 hours of initiation of RRT, when the activity of the erythromycin 14C erythromycin breath test was conducted, it was shown that there was an increase in the activity by around 27%, which is a surrogate for your cytochrome P3A4 isoenzyme. To simply sum up in one sentence, in AKI patients, not only the renal clearance, but also the non-renal clearance is affected. And this non-renal clearance of the drug which is affected can be reversed once the patient is initiated on the renal replacement therapy. Now, many factors are altered in critically ill patients, and they have some effect on the pharmacodynamics in these patients. Certain factors to be considered are the fluid overload state. Fluid overload will increase the volume of distribution, and there is increased capillary permeability, which also increases the volume of distribution. So whenever there is an increase in the volume of distribution, you have to give a larger dose of the drug. Hypoalbuminemia is commonly associated in septic critically ill patients. Here, the drug availability is increased, so the drug elimination is also increased. So you need to potentially adjust the dose of the drugs, especially for high protein bound drugs. Renal clearance is augmented in sepsis, so the drug elimination is also increased. So you have to give a more frequent drug dosing. AKI definitely will decrease the drug elimination because the GFR is affected. So you have to adjust the dose of the drugs which are being eliminated by the kidney. In patients requiring AKI with RRT, the drug elimination is increased. So dose adjusted as per RRT modality has to be chosen. In patients with preserved non-renal clearance, the preserved drug elimination in the face of AKI, there is preserved drug elimination, so you need to give a more frequent drug dosing. In patients with increased cardiac output, there is obviously increased drug elimination, so you have to give a more frequent drug dosing. In patients with impaired GI motility or reduced GI blood flow, the drug absorption is decreased, especially when you give through the oral route. So you have to avoid the oral route of medications for such patients. So these are some things which we have to remember when we are dealing with the critically ill patients. Now, there are many factors which influence the drug dosing in patients with an acute or a chronic kidney injury. These factors can be patient-related, drug-related, or they can be based on the type of RRT we use. First is the plasma protein binding. Plasma protein binding determines the free fraction of the drug, which is the physiologically active form of the drugs. Drugs with high plasma protein bonding, the quantity or the fraction of the drug which is available for action is low. That is, the unbound drug is the drug which exerts the physiological effects, and hence for the drugs which has high protein binding, the unbound drug or the percentage of the unbound drug available is low. High plasma protein bound drugs form large molecular weight drug protein complexes, and they are difficult to eliminate, and they are not even easily dialyzable. Plasma protein bonding will be decreased in renal disease because of hypoalbuminemia, uremia, which will lead to an increase in the free plasma fraction of the drug. Next is the volume of distribution. It is a concentration that the drug will acquire in the body when you imagine your body as a single compartment. Rather, it is the degree to which a drug will distribute in the body if you think your body as a multi-compartment model. That is, a part of the drug will remain in the vascular compartment, and a part of the drug will dissipate into the tissues. So the part of the drug that dissipates into the tissues represents the volume of distribution. High volume of distribution means that the drug will penetrate into the tissues at a higher concentration, and it is more lipid soluble. Lower volume of distribution means the drug remains in the vascular compartment, and hence the drug can be easily dialyzable. Drugs with high volume of distribution should be given at a higher doses. High volume of distribution means it is highly distributed to the tissues, so you should give a higher dose, and they are not easily dialyzable because they settle down in your tissues. The loading dose of a drug which we give is dependent on this volume of distribution. There are certain drugs which are hydrophilic, and there are certain drugs which are lipophilic. Examples of the hydrophilic antibiotics include your beta-lactams, aminoglycosides, your glycopeptides. And lipophilic drugs are the fluoroquinolones, tetracyclines, and macrolides. Volume of distribution, as I said, is nothing but the amount of drug in the body divided by its plasma concentration. If you imagine your body as a single compartment, the volume of distribution will be equal to the dose you administered to the drug concentration at time 0. If you imagine your body as a multi-compartment model, that means once you give a drug, the drug gets distributed in your body and it has multiple VD values. That is, a portion of the drug is in the vascular compartment and the portion of the drug is in the tissues. At some point of time, the amount of drug in the vascular compartment and the amount of drug in the tissues equilibrate, resulting in a steady state volume of distribution, which is nothing but your VSS, steady state volume distribution. And your loading dose of the drug depends on this steady state of volume distribution. Higher the volume of distribution, longer is the elimination t-half, because most of the drug gets settled down in the tissues. So your loading dose, as I said, will depend on the volume of distribution at a steady state, whereas your maintenance dose will be calculated based on your renal clearance. Loading dose uh, should be given only for a fewer drugs, whereas maintenance doses should be given for all drugs. Loading doses will rarely need a modification, whereas your maintenance doses need to be adapted according to the renal clearance. That is, your maintenance doses are variable. Now, the clearance. Clearance again depends on multiple factors. It depends on the properties of the RRT, like the type of RRT, the filter you're using, the material of the filter, the surface area, permeability of the filter, the RRT flow, the ultrafiltrate flow, the blood flow, dialysate flow, pre and post dilutions, the membrane pore size, sieving coefficient, and so on. All forms of RRT worked through two different therapies, that is a diffusion and convection. By far, convection therapy removes antibiotics of higher molecular weight compared to the diffusion therapies. Now, whenever you have to start a drug, have a stepwise approach. Step one, you always obtain a history and the relevant demographic and the clinical information, which will help you guide the site of infection and probably the antibiotics you have to use. Step two is always estimate the GFR of the patient. Remember that GFR of the patient in the ICU is dynamic. It keeps changing, so you need to reassess it at fixed intervals. Always review the current medications, calculate the individualized treatment regimen, and monitor the effect of the drugs, monitor the effect of the patient on the patient, see if the infection is getting reversed or if they are worsening, and revise regimen accordingly. Principles of medication dosing is like you always should follow, or you should always review the literature for the drug dosings that are clearly evaluated and published. Estimate the renal function of the patient by various methods available. Whenever available, always use therapeutic drug monitoring, especially for drugs with a narrow therapeutic index. Consider the mechanism of action of the drug and the pharmacodynamic evaluation of the drug. Now, antibiotics can be divided broadly into two pharmacodynamic profiles, that is the concentration dependent antibiotics and the time dependent antibiotics. For time dependent antibiotics, it is important that you maintain a certain concentration of the drug for a particular amount of time. That means you have to maintain the concentration above the MIC for a particular time. For a concentration dependent antibiotics, the peak of the peak concentration of the drug above the MIC is important. So that means uh, for drugs which are time dependent, you are supposed to give more frequent dosings, whereas for drugs which are concentration dependent, you have to give a single large dose. And this dosing becomes more difficult, especially when you are using a combination drugs like your BL-BLI combination drugs, because the PK/PD of individual components of the drug will differ, and this becomes more difficult when you are using supportive therapies like the extracorporeal therapies. Now, when you think of AKI and adjusting the drugs, remember to categorize your patients into three different phases of AKI. Phase one involves the declining renal function, and this phase you have to lower the doses of the drugs according to the magnitude of the failure. Urine output may probably help you in titrating the renal function in these patients. Phase two is the plateau phase, where there are minimal changes in the renal function, but dosing adjustment should be considered based on the renal clearance and the type of RRT and the presence of residual renal function in such patients. Phase three is the recovery phase, wherein you back off the RRT. So in these patients, dosing should again be reassessed and readjust. Post-AKI dialysis is a challenge to the clinician, and it may confuse you because here the GFR varies very rapidly. Multiple RRT system properties also affect the drug. Uh, the two main mechanisms, as I said, for the solute removal are diffusion and the convection. Uh, the ultrafiltrate helps in fluid removal. Diffusion simply means that the movement of solutes occur across the hemofiltration membrane down the concentration gradient, and hence small molecules can be easily removed. Convection means the movement of solutes across the membrane, and this occurs along with water as pressure is applied. That is, they follow a mechanism of solvent drag, and hence larger molecules will be removed. Now, longer the time of dialysis, higher the blood flow, higher the ultrafiltrate rate, higher is the dialysate fraction or the dialysate flow, more of the drug is removed. By far, the intermittent hemodialysis, CVVHD, and the hybrid form of dialysis utilize diffusion, whereas CVVH primarily utilizes convection. CVVHDF is a hybrid therapy which uses both convection and diffusion for drug removal. Hence, drug removal is greater in CVVHDF. So, efficacy of drug removal is higher in CVVHDF and lowest in the intermittent hemodialysis. There are certain biochemical and clinical markers which can potentially help a clinician to see if the drug clearance is significantly decreased. Uh, One, if the GFR is less than 45, two, a stage 2 or 3 AKI, three, in adult patients without a baseline creatinine, a creatinine value of more than 2 in adults or more than 1.5 milligrams per deciliter in elderly or those with low muscle mass, or a plasma creatinine which is greater than 2 times the upper limit of normal for the age and weight in children without a baseline value, and the presence of oligoanuria. These few biochemical and clinical markers will warrant a physician that the drug clearance of the kidney may be significantly impaired. Now, there are certain things you have to consider while you drug dose for patients on the intermittent form of dialysis. By far, this is the most common form of dialysis, and it is a high flux dialysis. Remember that in intermittent forms of dialysis, you will have two distinctive PK phases, that is one during the dialysis, that is the intra-dialytic value, and inter, that is in between the dialysis. Similarly, you will have two elimination and two T-half values, which are nothing but the values during the dialysis and in between the dialysis. The intradialytic elimination of the drug is faster compared to the interdialytic elimination. The extent of drug removal is also dependent on the plasma drug concentration and the time interval between the drug administration and the start of RRT. Ideally, the start of RRT should be towards the end of drug dosing, and a supplement dose should be given at the end of dialysis. Some recommend to give the drug dose during the last hour of dialysis so that you can achieve a good therapeutic level of the drug, and also you can eliminate the drug, thereby the side effects of the drug can be minimized. So remember that in intermittent hemodialysis, you are dealing with two distinctive PK values, two distinctive eliminations, and two distinctive T halves that depend on whether the patient is in the intra or the interdialytic period. The elimination is faster during the intradialytic period, and T halves are smaller during the intradialytic period. So most of the drugs during intermittent hemodialysis ideally should be given at the end of the dialysis, in the last hour of dialysis, with an extra dose after the end of dialysis. And in these patients, RRT should be started at the end of the dosing interval. A supplementary dose in addition to the dose adjusted to renal failure should be considered to replace the fraction of the drug that you removed during dialysis. Extended dialysis with high diffusive membranes are associated with extensive drug removals, and hence a supplemental dose should always be added. So for concentration dependent antibiotics, like I said, aminoglycosides, high doses with extended intervals seems to be an optimal dosing method. And for time dependent antibiotics like beta lactams, reduction in the dose, maintaining the dosing intervals seem to be optimal. Now, CRRT, unlike the intermittent form of dialysis, has a relatively constant drug clearance. The intrinsic renal clearance and the CRRT effluent rate will provide us a guide to the starting point. CRRT will significantly increase the clearance rate of drugs which are eliminated by both renal and non-renal ways. But remember that though CRRT is effective in removing the drugs, it is not as effective as your native kidney. And whenever possible, the therapeutic drug monitoring should be utilized in patients with CRRT. Remember, unlike in intermittent forms of dialysis, where you have to give drug dosing during the end of dialysis or during the end of the interval period or post dialysis, where you have to give an extra dose, there is no such thing applicable in CRRT patients because it is a continuous process. So by all this, I simply understood that you have to individualize therapy and there is no fixed one formula which can be fitted for all patients. So whenever I have to individualize the therapy, I will take certain points into consideration. One, the RRT prescription. Definitely the method of RRT, or whether the patient is on the intermittent or the continuous form of dialysis, and I will see if there's any residual renal function or preserved diuresis. If there is residual renal function or preserved diuresis, probably we need to give a higher dose of the drug. Second is the comorbids of the patient. If the patient is having ascites, or if you're dealing with a pregnant patient, or you're dealing with a patient with extreme degree of burns, where there is third spacing, we most of the times tend to underdose these patients. And whenever you are giving a drug, look at drug specific toxicities, like certain drugs will cause ototoxicity or nephrotoxicity at a particular level. Look at drug to drug interactions and see if there are any additive effects to the drugs which you are giving in combinations. Next, the type of filter we use. High flux filter, the antibiotic clearance is higher, especially for the drugs which are dependent on the diffusion method of modality of RRT. So we need to give a higher concentration of the drugs, especially when you are using diffusion as your RRT modality. Then look at the immune status of the patient. In immunocompromised patient, it is always wise to consider bactericidal drugs, and definitely you need to give a higher dose of drugs. Look next at the site of infection. For suppose if the site of infection is a bone, a joint, myocardium, or the CNS, you need to give higher dose of the drug. The initial dose, always remember to give full doses because the volume of distribution is higher. So you have to give a full initial dose, especially in the first 24 hours, and that too in critically ill patients, in hemodynamically unstable patients. You have to be cautious in patients who are having a seizure history, because you might lower their seizure threshold. Consider de-escalation if the patient is clinically improving, but the renal functions have not improved. Maintenance doses will depend on the type of RRT the patient is on. Maintenance doses definitely will need modification, whatever form of RRT we are using, exception being CRRT, where the maintenance doses need not be very low as compared to non-AKI patients. For drugs like aminoglycosides, they are better given before dialysis so that you reduce the toxicity. The pre-dialytic and the intra-dialytic doses should be more aggressive. And for drugs where the therapeutic drug monitoring is available, it is always advisable to look at the drug levels and then space your maintenance doses accordingly. Presence of multi-organ failure. In multi-organ failure, apart from your renal clearance, even the non-renal clearance is affected. So your drug clearance by other forms of excretion is also affected. So if you are not only dealing with a renal failure patient, you are also dealing with a patient with hepatic failure. You have to be more cautious when you give the drugs. Next, the duration of the RRT and the flow of RRT. Longer the duration, higher the blood flow, higher is the drug removal. So extended periods of dialysis with high blood flow will eliminate the drug faster. Next is the severity of infection. Mm, for uh, for infections where you give beta lactams and vancomycin, you should always consider a loading dose, and you need not decrease the loading dose of drugs. And in septic patients, remember that you are giving an aggressive fluid resuscitation, and sepsis is a hyperdynamic state which warrants you to give more aggressive antibiotic dosing. Consider delay in the dose adjustment for 24 hours. That means be aggressive and give full doses of the drugs in the first 24 hours, especially in septic, critically ill patients, irrespective of their renal function. When next look at your antibiotic of choice. If you have a culture report, consider antibiotic based on the culture reports, and consider the antibiotics where you have robust data about the PK/PD characteristics of the drug if bugs are susceptible. In patients with AKI or CKD, remember that in patients with AKI, the drug elimination may be faster when you compare to the CKD patients. Last but not the least, consider the weight of the patient. In patients with increased BMI, consider to give higher doses and more frequent doses, particularly when you're using lipophilic drugs. Last but not the least, it is always wise for you to remember the list of drugs which need no dose modification in patients with AKI or CKD. So, as I said in the beginning of my talk, the antibiotic dosing in dialysis patients is by far one of the difficult topics in the human science, because we hardly have any data based on good clinical evidence from multi centers. The reasons being many, because probably we are still understanding the pathophysiological process of sepsis. The definition of AKI is still evolving. Different people have different thresholds for clinically describing AKI. The antibiotics which we are using, there are a wide range of antibiotics which we are using for the same clinical condition, and so on. So this simply means that we have to individualize the antibiotic therapy in patients with AKI. And as I said, these are the few points I would consider when I start my patients on a particular antibiotic when they are on dialysis. Thank you.